because you've just spoken to me. Thank you for that. Luann Grugan.
Hi, good morning.
Good morning. Councillor Al Samurai has tendered apologies. We have Councillor Cook.
Good morning, folks.
Councillor Bell. Let's see if he's on the attendance list. No,
He had
not
a briefing.
showing.
Sorry, he had a briefing with Care and Repair, I know, before this meeting, so it's maybe overrun.
Okay, I'll just put a wee invite to him so he remembers. Thank you for that, Councillor Dunbar. Councillor Dunbar.
Good morning.
Good morning. Kim Crittenden.
Morning.
Good morning. Alan Gray. Seeing Alan there yet. Taking off that one. John Tomlinson.
Yes, yeah.
That's the voting members confirmed as sufficiently for quorum purposes, Chair. I'll continue with the rest of the roll call. Sandra MacLeod.
Good morning.
Good morning. Alex Stevens. Yeah. Dr. Caroline Howarth.
Good morning.
Good morning. Chris Littlejohn has tendered apologies, Chair, as has Mike Adams and Jenny Gibb. Jim Curry. Not seeing Jim and call you. Graham Simpson. Not seeing Graham. Maggie Hepburn. I can see
Good
Maggie.
morning.
Good morning. Shona McFarlane.
Good morning.
Alison Murray.
Morning.
Dr. Gemmell. Howard. No, not here today. The clerk is present. Angela Scott sends apologies. Jess Anderson.
Jess sends her apologies. I'm here instead, Derek.
Thank you for that, John. And Alison MacLeod. Alison's not here, that's fine.
Hi, sorry, Derek, I am here. Just
Oh yeah, sorry, I
I
didn't.
I
didn't see you in the list. Appreciated, thank you. That completes most of the roll call, Chair. There are other attendees as authors and overviewers of the system today as well.
Thank you, Derek, and welcome everybody. So just a couple of matters about how we'll conduct the meeting this morning. I notice that, sorry, I've just lost my papers. Here we go. We've got on the daycare item on item 13, there's an appendix 1, which is actually a restricted paper. It was the paper that came to us in August and it's there for information. But if members have any questions arising that are in that paper, we might have to go into private session. So it would probably help the smooth conduct of the meeting if we try and avoid questions that touch on topics that are in appendix 1 that might be restricted. But officers are aware and they'll give us guidance if we need to stop the discussion and turn off the recording. We're also going to have some any other business at the end of the meeting in private session. So after item 15, where we're going to get an update on some care issues that are going on from the Chief Officer. Okay. Right. So do we have any declarations of interest? I don't see any hands up. Okay. We've got no specific section for exempt business apart from the any other business at the end of the meeting and whether any discussions arise from appendix 1 on item 13. So now we turn to the standing items. We've got the minutes of the last board meeting on the 8th of September. I'll take that for accuracy first. So page 7, page 8, page 9, page 10, page 11, page 12, page 13, and page 14. I don't see any comments on accuracy. Are there any matters arising in this from this minute that people want to raise now? No, no hands up. That's good. So we'll take those minutes as accepted. So item 5 is the minute of the board meeting of the 2nd of October. So again, for accuracy, page 15, 16, 17, 18, and 19 is just the board resolved to close the meeting. So any matters arising from that minute? No, no hands. That's good. So we'll take that as an accurate record as well. Thank you. Item 6 is the Risk Audit and Performance Committee minutes. These are for noting. And John, do you have any comments you want to make on that meeting or anything?
Thank you, Chair. No, just to emphasise that we've now caught up with the work, and I'm very thankful for officers for achieving that. We have another meeting coming up, and that will complete us getting fully on track. The next agenda is quite light, but that's just because we're then getting on track for the quarterly meetings, which will commence after that. So that's really where we are.
Okay, thank you. And we have the minutes. Item 7 is the Clinical and Care Governance Committee minutes from the 22nd of September, again for noting. Leslie, do you have any comments you want to make?
Just that we had the flu immunisation item escalated to today's meeting. And we also had a very helpful and informative briefing from Chris Littlejohn around test and trace.
Yeah, it was incredibly useful, yes, and very relevant. So the flu item, we're coming to that in the Chief Officer's report. So we'll take that was the escalation because we wanted to ensure we had the most up-to-date information for everybody. So thank you.
Thank you.
Okay, so we're noting that as well. And now we're on to the business planner. Right, this is a moving feast of information at the moment because we're still catching up with some business that we didn't do because of COVID shutdown, but also a huge amount of new items have been added in as we've been remobilizing and transforming services. Alex, can you give us an introduction to this, please?
Yeah, I can do, Chair. Thank you. I think in terms of the items that are on today's agenda, they are covered within the business planner as it sits at the moment. But just to say that there's a 2C, a GP practice 2C redesign, which will be discussed in December. So I'm just flagging that as it sits at the moment. December is busy, but I'm seeking after further discussion with the authors of the reports. We think we can take some of these reports off and move them into the January meeting, and understand there's a paper on looking at a 23rd of January 2021 paper. So if the board was in agreement, I would be seeking to keep the Chief Officer report on, to keep a report on localities, to keep the 2 mental health reports on, and the ADP report, the strategic risk report, and also the 2C report that I mentioned before. So the focus of the agenda would become mental health, alcohol and drugs, 2C redesign, and also the risk register. And then we would work with the authors to push some of that other stuff back into January to give some information from there. And in January we will start to get into the budget process as well. So there may be information that starts flowing as a result of that as well at that point in time. The one thing I would say about January in terms of our normal financial information that we bring is that the 23rd of January will be quite tight for me to be able to bring the Q3 financial information to you, but we'll try our best. It will likely be another late report just with the timing of the IJBs to actually get that through to you. But I think given the importance of it, that it would probably be worth making that effort. So that's where I am, Chair. I hope that gives you a little bit of confidence around about what we're doing. But certainly the discussions that I've had, some of these reports could push back into January, and I'll be seeking to work with report authors over the next month to determine exactly which ones they are. But the basis of the agenda would be as outlined previous. I've just outlined.
Right, great, thank you, Derek. Because honestly, December was looking like an unmanageable meeting for us all, to be honest. So I think it's a good idea to have a meeting in January and defer the scheme of governance and localities stuff until then. Does anybody have any comments or questions on the business planner? No? Okay. So we'll the chair, vice chair, and officers and we'll discuss the business planner and we'll update it, and we'll go on the presumption that December won't have all of the items that are listed in this document, but will have the items that Alex has listed. So just December becomes a much better meeting, I suspect, because 2C is a really big issue for us to consider. So we need to make sure that we have enough time to do that properly. Right, thank you. Chief Officer's Report, item 9. Sandra, you want to come in on this?
I can do, Chair. I see Luann has her hand up. I wasn't sure of that.
Sorry, I didn't notice that. Luann?
Sorry, I'm on my phone, so I'm a bit slow with the buttons. It was just to clarify, were we saying that localities and the leg report will come to December, or is that one that's being moved?
That'll go to January.
I could go wherever you want it to go. It's ready to go just now. If the chair and the vice chair decide to push that out, I'm not aware of us needing an urgent decision around about that. That paper is ready, and it's one paper. It's not two papers. So we would combine these two items.
Okay.
But
okay, we can maybe discuss that.
Yeah.
Okay.
Thanks.
Thanks, Luann. Right, Chief Officer's Report. Over to you, Sandra.
Good morning. Thank you, Chair. You have before you the Chief Officer's Report, and it highlights several areas and gives you several updates, but there was a few things that I would like to just bring to the IJB's attention. First of all, on the flu vaccines, just to say that there is a weekly update that's been circulated. Hopefully everyone's having sight of that now, that's been the one that's been shared with the NHS board, has then been shared with both our IJB and elected members more widely. So hopefully that will keep everyone up to date with real current progress on how we're moving forward. From an overview from the city perspective, and I think given the escalation from CCG, in the city we have venues we're accessing possibly across 17 different sites. We've been running between 2 and 9 clinics every single day. We've further clinics planned and in progress. There's been really positive feedback from people who've attended the clinics, which, given the restrictions around the appointment times that we have to put in place, the social distancing measures, and some issues we've had with regarding letters and issuing and the promptness of those, has been exceptional. We appreciate that there is work to do, and we continue to improve the overall efficiency of the process. The teams are working extremely hard to modify, to learn, to implement as we move through this, and their hard work across the whole of the teams is appreciated, as is the continued support of the IJB and the wider community. So the flu vaccines are progressing, and we'll give a fuller update later. Home First, we're progressing well with many of the projects at critical operational design and delivery stages, so there's a huge amount of work that's been undertaken there. The evaluation framework and data sets are progressing well, and those will be fed through RAP. We had an update this morning on the Home First on that evaluation. Aberdeen Together, just really to highlight there that these projects highlight the continued joint working with Aberdeen City Council, the third sector and our communities to progress and build on the positive developments, links and relationships that are formed. And we look forward to bringing the localities paper, whether that be December or January, which is also going through the Community Planning Board as well, which will really highlight some of the joint working that's progressing. Also noted in the paper is the criminal justice inspection has been stepped back up. That commenced on Monday and is commencing well. We'll bring back the final report for IJB in February, I think it is, when that's published. We do get initial feedback in November and December, but that will be in draft form. So when the paper is approved, we'll bring that back with any recommendations and actions. The staff teams have done a considerable amount of work in preparing for this and to ensure we're prepared as possible, and also to highlight the continued work that criminal justice do in ensuring the public safety, particularly around about the COVID time. And I think that it's really important to take an opportunity to highlight the support that the teams have given to people who were released from prison during lockdown, the increased numbers that we have from diversion from prosecution numbers, particularly around about our women and young people, which is a huge positive, and also for those the continued ability to support, to supervise of high risk and high need offenders during the COVID period. The team have been working extremely hard, so we look forward to seeing the outcome of the inspection, but appreciate that as with any inspection there will be positives as well as negatives in that. The remobilisation plan, I think there's some detail in the report there, but again, really just to give assurance to the IJB that we have contributed to this, participated and engaged with the process, the planning, and will still be and are around the implementation. The final thing I would just like to raise is about Scottish Government consultation that's on about IJBs moving to Category 1 responders, and the consultation is about any unintended or unforeseen consequences of that. We foresee no, given the close working relationship across the North East and the areas of delegated services, we foresee no unforeseen circumstances or impact, but we shall just wait to see what the outcome of that consultation is. So happy to take any questions on that, Chair.
Okay, thank you, Sandra. I'd echo the comments about the work that the criminal justice team have done during lockdown. I see John Tomlinson and then Alison Murray. John.
Okay, thank you, Chair. I'm not sure, I've got questions on two different things. Are you wanting to take things in order, Chair, or my first?
Let's put all your questions. Let's see how we go. Yeah.
On the immunisations, I just wanted to get clarity in my head about who's doing what with this, because we had reports for the IJB and committees previously in the build-up, and then suddenly NHS Grampian are kind of fronting the thing, and I'm just wondering just what the setup here is. Is it through our IJB with that hat on, like today, that we're and through yourself running that for the city, or is NHS Grampian doing it for the city? I'm just a little bit unsure on that, because it could be like care homes. I'm not sure, but if you could explain that. The other one was just on this Category 1 responder part, and whether there was anything further the IJB needed to consider in this, as opposed to noting that it's happening. Just in terms of our responsibilities on the board would seem to be a bit different. I'm just not totally clear on what accountability we have on that. If you could just clarify that, that'd be great. Thanks.
Okay, thank you. I shall do my best to clarify both those questions. If there's anything unclear, I can come back. The immunisations is something that is it is a joint perspective that's been taken forward. So there is a steering group that's been working towards, and an implementation group that's working towards the flu vaccine. So Aberdeen City is part of that response. So there's been some of the centralised function has been the NHS, for example, the pulling the data, the issuing of the letters and the administration part. The actual practicalities of delivering the clinics, the staffing and moving towards that has been our component of that. But there's very close working relationships. the reason the NHS have taken the lead, NHS Grampian have taken the lead in issuing the information on a Thursday and taking that lead is because they hold that central point. So it felt that it was a better coming from one single point rather than 4 different messages coming through. So just to keep a consistency, but just mindful, we're absolutely cited on that. And there are, I think there's nightly calls Monday to Friday with the flu forum. So there is a lot of work and a lot of joint partnership on this. So hopefully that clarifies, but there's bits we're both doing, but it is an overarching programme. With regards in the Category 1 responder, my understanding is that from an IJB's board's perspective, is that the direct employees, if you like, of the IJB are myself and Alex, Chief Officer and Chief Finance Officer. So generally that's the direct resource that the IJB can bring forward, if you like, to any Category 1 responder, but it's in response to the delegated services. And being part of that Category 1 responder means that when we are able to use the services that are delegated to us will be far more around the table. I would say that during the more recent COVID response from an LRP, we were absolutely around the Grampian-wide forum around the tables, but we're very much as a listening partner and part of that response as opposed to being a Category 1 response. So I think our role in this, it feels as if it just slightly formalises what we have already understood and had undertaken during the pandemic, given the positive relationships that are locally in the Northeast, but that may not have been similar across all of Scotland. So we foresee that that's possibly how some of this has been formalised. Does that help at all?
That does very much. I think on the first one, it just emphasises how we probably, when we're considering issues, it's something we can just look into as to the respective roles rather than make assumptions, from our part, which might or might not be right. And then the other one does clarify. So from our point of view, we're assured that we've got the processes through yourselves, but this gives you a different seat at the table, if you like. So that's very clear. Thank you very much.
I'd just come in on the back of that, and then I'll take Alison, because it's about the Category 1 responders. So am I right in thinking that this will mean that we have an equal voice in the strategy for dealing with these kind of emergencies? At the moment, although we've been around the table and obviously input, we haven't had that role formally, but we would formally now be one of the decision makers about how to respond. Is that right?
That is my understanding, Chair, but I'm wondering whether Martin is around, whether he would have anything to add on that. Martin, is there anything you'd like to add, just for clarity?
Thanks, through you, Chair. No, I agree. I think it's the formalisation, I think will help to just kind of back up the foundations already in place. Yeah.
Okay. I mean, I think it's a good thing that the status of IJBs is being recognised as an equal partner across Scotland now. So I think, provided there are no consequences that we can see that would be negative, and there don't seem to be, I would support it. Right, Alison, over to you, then Kim.
Hi, thanks. I've had quite a few queries about when and how unpaid carers should access the vaccinations. It's been quite confused. I mean, a lot of people are just not knowing how they're meant to, and I've know quite a few people who are paying privately because they think that's the only way they can get a vaccination. A lot of unpaid carers are not registered with GP practices, so will not receive a letter saying come to have a vaccine. I myself have phoned up about 6 times and had various different responses before I've now got an appointment tomorrow to get a vaccine. And I was just wondering if more could be done to try and reach unpaid carers who may or may not be registered, and young carers as well. My daughters are also young carers. They helped care for my son, though they've both decided they don't want the vaccine. But I think it's a group of people who are actually being missed, particularly those who won't be registered, so won't get a letter because they're not registered, or might not realise they needed to have been registered to have got a letter, so might not realise that they won't get a letter.
Thank you. I'll try and answer that. I would say that the criteria that we send out the letters is based on the information that we have from Scottish Government. So there's a set protocol for how the flu vaccines are administered, in what order, and in which groups are being brought forward. We are aware that that there has been a public campaign. We know that the letters and the website and how we've progressed and has not been as smooth as it could be, and there is a huge push to really encourage that. With regards to unpaid carers and staff as well, that is all progressing. I'm wondering, Alison, is there anything that you would like to add on to that? Sorry, Alison MacLeod, you would like to add on just there, but I think it is, we have to follow under the direction of Public Health and Scottish Government criteria about who and when gets the initial letters for the appointments. Alison, do you want to?
Yeah, thanks, Sandra. There's a different route, if you like, for carers. The flu vaccination programme that NHS Grampian and the partnership are progressing is mainly focused on the over 65s, the at-risks, and the 2 to 5 year olds, and then finally the new cohort of 55 to 64. But there's a separate route for paid staff, paid health and social care staff, and a separate route again for providers or staff providing social care in commissioned providers, and indeed unpaid carers. So unpaid carers would go through the pharmacy route. They would go to their community pharmacy, and they would just need to be basically advised that they were unpaid carers. Now that information is on the Grampian Flu website, but there's certainly probably a bit more that we can do in terms of publicising that by linking it to our adult carer support service, and indeed the young carer support service as well. So that's something that I'll take on board and make sure that we publicise that a bit better if people are slightly confused as to what route to take. So I'll take that as an action.
Yes, it's not just carers themselves who are confused, because they don't know, particularly if they're not going to receive a letter because they're not registered, so they have no idea when or how they're meant to actually access. It's also the flu helpline staff, because I was given a whole load of messages and I expected to be told, oh, we're doing it in a different round or something like that, but no, they've booked me into an appointment for a clinic. So obviously they don't know I'm meant to go to a community pharmacy either, because I wasn't told that, and other people have been told different things. So the carers just don't know what's happening, and neither, it seems, does the flu vaccine helpline, who I've had different messages from as well.
Yeah, there have been some issues with the helpline in terms of with the volume of calls that they've been getting. There's been a lot of additional staff who are perhaps not been trained in the same way as the core staff. So totally accept that perhaps there have been some confused messages, but we've now got a dedicated flu helpline, and the staff there should be more aware of the information. So apologies for that confused information that you've got, but I'll feed that back and make sure that the information is as up to date as it can be with the staff who are providing the advice.
Okay, but so I can feed back to other people. The carers are meant to now go to community pharmacies and tell them that they're unpaid carers and they should get a vaccine from the community pharmacies.
Yeah, there is a form on the website. If you access the Grampian flu vaccination website, there's information there, and there's a form that they need to take along, because obviously community pharmacies will need some sort of record that they are an unpaid carer.
And do the community pharmacies have adequate supply, because they're not having any for private? A lot of them haven't got private supply.
I'm sorry, I can't comment on the supply that's available there. I would need to check that out. We've certainly in any of the meetings that I've been in, nobody has raised any issues about vaccine availability.
Okay, thank you.
Okay, thanks for those actions, Alison McLeod. Thank you. Kim, and then Luann, and then John Cook.
I wondered if you wanted me to come back on that with my pharmacist hat on, actually, around vaccine supply. I can certainly find out officially, but there was considerable concern around at-risk patients paying for their vaccine, and of course within COVID times more people are choosing to be vaccinated, and certainly they had long waiting lists to get people in, so there was quite a lot of concern around supplies because there's been no additional allocation based on this, because allocations were made before COVID arrived on our doorstep, unfortunately. So there's been no additional. So I think that that supply chain is quite considerably at risk. But if you'd like more of an update, I can certainly find out the kind of official position with my pharmacy hat on, if you'd like. But my question were, unfortunately, sorry, Sandra, staying on the flu vaccine thing, just for clarity. So I know that the figure now I think is more like 60,000 people across Grampian, I think was the last figure I saw. I just wondered proportionally what the city figures were if we had those. And then on top of that, it says, you know, we're aiming to vaccinate about 225,000 people, so not far off half of our sort of Grampian population. And I suppose I wondered where that figure came from. And then bearing in mind that if I'm correct, we're about a third of the, maybe not quite a third of a way through the time for the vaccination period. So the 3-month period, we're maybe about a month or so into it. We've vaccinated a quarter of what we're expecting if it's about 60,000 people at, you know, at this current time. But we're talking about pressure on vaccine supply chain. Whereas I'm thinking actually we should have vaccinated more by at this point in time based on the figures. And I'm just wondering, it talks about redistributing the vaccine, but is that redistributing throughout Grampian because it's in the wrong place? Is it throughout Scotland? It's just a bit of clarity, because, you know, if you just look at the figures, it sounds like we've not been allocated enough to Grampian for the figure that we're trying to vaccinate. And I suppose looking at, you see a lot of things on social media, and there's been a fair bit of bad press around the letters and things. And I think if it's compounded by vaccine running out, it's not going to look very good to the general public.
Okay, Kim, I'll certainly try and answer a few of those questions, and also we'll ask Alison McLeod to come back in if there's anything that she can supplement. I would reiterate the same as what Alison said. We're not aware of any vaccinations, if they're having anything in the supply chain that we've been aware of. We are aware that there was, I think we are aware of issues with the letters, where there's wrong letters have went to the wrong cohorts, and therefore there was, and the planning of the vaccine has been held back. So that whether that's where that's came from, I'm not sure. We're also absolutely aware of some of the negative attention and focus on with regards to the letters, and rightly so, I think. But I would say that the team has been working extremely hard, the whole team across Grampian, NHS Grampian, and our local teams, to make sure that that's addressed. Part of the reason that we're not as far through the vaccines as we would have hoped to be at this time is part of that scheduling about how, so initially we thought there would have to be 30 minutes a time, 30 minutes between each patient with social distancing and with what's going on. But actually what we're down to, I think the efficiencies, the nurses are down to about 8 minutes. So we now know, and as in on our future planning for what we originally cohorted and what we originally thought we would get through in vaccination clinics, that's significantly increased the numbers that we can pull into clinics. So although I would suggest that what we vaccinated in our first cohort will not likely reflect what we'll vaccinate in our next round of clinics, because we're much more aware of, and as I said, we're taking that learning and progressing that as we go. From a city population, we're waiting for the percentages to be exactly given. There is data that comes out on a daily basis, but the data that we have excludes all primary school children. So primary school children, to my understanding, we're totally on target with that, and that's been done through a different route. The figures that we get on a nightly run those don't include children, they don't include anybody picked up by GPs, they don't include anybody picked up by pharmacy, so they're very light. So at this moment in time, we would know that we'd vaccinated just over 20%, but we do understand that that's a low figure because it does not include any of that other cohort. The reason where the data came from, my understanding is that that came from public health. So we looked at the population across all the risk groups. All that was identified, which volume were in each risks. And then the government have stated a target about 75% cohort. So that's where the figure came from. It was worked up on the population in each category at that estimated amount, which doesn't, that's our target, if you like, but doesn't accrue for any DNAs, people not attending clinics or choosing not to have their vaccines. Alison, I'm not sure if you want to supplement any of that, and hopefully I think I've answered most that, Kim, but I'll certainly let Alison add anything supplementary.
Yeah, I was just going to add perhaps the figures as of this morning that we have, just excluding the primary school children, as Sandra has said. But if we just focus on the over 65s and the at-risk categories within Aberdeen City, the total that we would expect to, or our total that we have to vaccinate is 68,161. And as of this morning, we have vaccinated, oh, sorry, I've just lost my sheet of paper with that on. We've vaccinated 23,306, which equates to 34%. So in terms of being, you're correct, we're approximately a third of the way through, and we've vaccinated a third of that high risk cohort.
So just for clarity, so that the overall figure includes children then, not the figure that we get from the Grampian figure that comes through, but the overall estimate of the number of people to vaccinate, the 2 to 5,
that initial figure
children.
It was including children, yes.
Okay, thank you.
Okay, Luann, then John Cook.
Thanks, Sarah. 2 questions. One just quick one on flu, really. Just recognising this is a huge piece of work and a big change to how this is to be delivered. All agreed pre-COVID, not knowing what was ahead of us, and all to be done between October and December this year. Is there a process in place for gathering, learning, both locally but also nationally around what's worked really well, what's been good practice, so that we can evolve and improve as we go forward, and particularly thinking ahead to COVID as well?
Sorry, Luann. Yes, there absolutely is. There's already, we have a hot debrief tomorrow from a local systems perspective on looking at what the learning's been, and there's already a steering group and an SRO being established for the COVID planning to start to put in just if there is to be a COVID vaccine, what that will look like. So absolutely, there's nightly meetings that bring forward the learning, but also the hot debrief on Thursday, which will take forward the formal process. And our staff and, for example, our project manager round about it, Joe, as well as Katrina Morrison, they're all linked in at national level, so are sharing all the learning that's coming through. So I think as a system across Scotland, there is a huge amount of learning as we're going, particularly with the volume and the uptake as well, which is normally quite difficult, but people are certainly keener this year for having their uptake, and we need to learn as we go to make sure that the COVID steering group, that we will be putting resource around that to make sure.
Thanks, Sandra. That's really good to hear. My next point really is about the adult social care national review. It's just to update IJB members that in Sandra's report she mentions that the chair, Derek Feely, will seek views from IJBs. Well, Sarah and I had an email just last night inviting us to a meeting on the 5th of November, so next week, to provide any views. So it's just a sort of an ask really of IJB members, if there are specific things that people would want to make sure we include in our feedback, please email me, or we can set up a phone call or whatever's going to work. Just bear in mind it's next week, it's the 5th of November, but just to let people know that I'm very happy to take any comments from people to feed into that review, and also to note separately to that, Alliance are doing work locally, which I'm sure Alison MacLeod can talk more about, but there are processes and arrangements in place to gauge community members as well. So that was just a comment.
Okay, thanks, Luann. John Cook.
Thanks. Yeah, it's flu again, I'm afraid. In terms of capturing the learning, can we look? One of the things can we look at is how people are being allocated to which centre. And the reason I'm thinking that is that there were folk who stay in Rosemount, but were being sent to, I think it was Northfield Academy. So presumably, whoever's organising it is using postcodes based on where your GP practice is, rather than where. And I don't know how easy it would be to do something, but I think the letters were being sent out from Livingston, so there's no kind of local knowledge. I just wondered if there's something we could do about that.
So absolutely, I think that there has been some learning around about that, and particularly around about how we move forward. In fact, just this morning, I'm contacted ACC because I think one of the things that, although might seem fairly obvious, has just came to us, is that the local authority is very adept at arranging elections, for example, and they're very skilled at that. And I think when we come into COVID in there, so I'm already touching base to say what learning could we have had, or can we have? And I think in particular we'll apply some of that. So no, we totally take on board that, and it has been unfortunate. I think the way the GP clusters in the city are proportioned, and then where they sit, and how that's been. I'm not sure, Alison, if there's anything to add to that.
Yeah, thanks, Sandra. I was just going to say absolutely. Although the letters were sent out from Livingston, it was based on local data, and people were allocated to a clinic nearest their GP practice on the basis that they would be registered with their nearest GP practice. But we appreciate that that's not always the case, and some people stay with a GP practice, although they move quite some distance away. So we thought that would be the most sensible way to do it. But absolutely, we have taken on board. We've had a lot of comments about people having to travel. So again, yes, learning for next time that perhaps we use the home address as opposed to the GP surgery.
Thanks, that's great. And just one other question. It's paragraph 3.7 on the remobilisation plan, and the diagram which is on page 9 of the report. Sorry, I'm doing that thing where I'm doing Teams on my laptop and looking at the papers on my iPad. We've got 7% of targets delayed, and 26% which have got minor issues. How worried should we be about that? Or are they minor, or is it something for us to worry about?
I think it's a collective on the mobilisation plan is something that is being brought forward on a regular basis through the chief execs, and it's been monitored quite closely through the whole team on that. So no, there isn't anything of huge concern at the moment. It's just how far on it is in its timeline. So we said we'd be completed by this date. Is probably some lag within it, but nothing that's causing huge issue at the moment.
Thanks. That's me done. Thank you.
Thank you. I'll just make a request on the flu point. I mean, I'm aware of quite a lot of publicity and chatter about supply chain issues. So it's and this has been raised today. Could we get some clarity on supply chain? Because we don't want stories starting here if we don't have a problem. So I'd be really grateful if we could just get an update on whether there should be any concerns with supply chains. I suspect that is something that has to be dealt with at a national level. So if there are, then it needs to be escalated and dealt with at the appropriate level nationally. But we don't want people not coming for their vaccination because they do the altruistic, well, somebody else needs it more than me and there aren't enough of them. We don't need that complication in this process either. Alison.
Thanks, Chair. I was just going to add that we do keep a constant look on our stocks as we use them, and we're actually doing an audit as we speak about how many people have we got left to vaccinate, and how many stocks, how much in the way of stock do we have, and ensuring that we have our orders placed soon. It's a different vaccine, obviously, depending on the cohort, so it's multiple stocks that we have to maintain, but absolutely we are continually monitoring that.
I think you're on mute, Chair.
First time for me today, won't be the last. Thank you. Shona, do you want to come in?
Yes, thanks for that, Chair. It was just actually to give my input into it. I actually did receive a letter. I'm in a different cohort, and I received the vaccination on Saturday morning. So everything went swimmingly and according to what the document says. So it was just to give the other side of it, to say that actually some of it is working. So I just wanted to say that. So that's just my input into it, and thanks for that.
Okay. Yeah, that's good to hear, and thank you for that. It's the nature of these issues that we hear about the people who are unhappy and when it doesn't work well. And it's often hard to get a handle on the scale of that compared to the silent people who are perfectly happy with the process. So I think we do need to bear that in mind. But there's obviously a lot of learning to take forward, not just for next year's flu, but really importantly for the COVID vaccinations that will hopefully be coming up soon. I'm sure we'll keep this on the agenda. Okay, thank you for all of that. We're just noting the Chief Officer's report, and she'll be back speaking to us in any other business at the end about care issues. Okay, right, next item is IJB meeting dates for 21-22. We're being asked, Derek, are you speaking to this paper?
I suspect I will be, Chair, thank you.
Okay.
In front of yourselves, Chair and members, is indeed a proposed event timeline for the meetings of both the board and the committees. There has been discussion with the chairs, vice chairs and officers to try and get as populated a year's plan as we can. The standing orders do permit, as we've known, sadly this year, having to do additional meetings, that we can insert additionals as they go through the year. We've tried to set the dates for the actual meetings so that there's a bit of a gap between all, so that we can respond interdependently within each committee, rather than have log jams through the year as we've seen a couple of times recently. It is all, of course, all predicated on the availability of ACC members and NHSG members with their competing demands. So what we've tried to do as best as possible. So the dates are there at 3.8, and at 3.9 we also have some standalone development workshop sessions that are planned for this year and then into the start of next year. There will be further sessions that will get added into maybe a different calendar format, but this is the formality as per standing orders of publishing our dates in advance. Happy to take any questions, Chair.
Thank you, Derek. I cannot overemphasize the complexity of organising and choreographing all of this, because it's not just the actual meeting dates that need to be factored in, it's the preparation time and the pre-agenda meetings and everybody's availability. So it's a huge amount of work that's gone into doing this. Does anybody have any comments or questions on this paper? Right, okay. So just for clarity, we're approving the IJB clinical and care governance and risk audit and performance meetings that are set out in table 3.8 on page 47. Okay. I'll go through the recommendations on page 45 of the pack. So we're reviewing and approving the meeting schedule at section 3.8. We're agreeing to publish the meeting schedule on the websites, and that's it. So if we're content to do that, then that's those recommendations approved. Thank you. that gives us some clarity on our schedule for next year, for the next sort of 14, 15 months. So that's very helpful. Thank you, Derek.
Thank you, Chair.
Item 12, this is NHS Grampian renewal. This is, who's going to introduce this paper? Who's speaking to this paper?
Chair, we had invited Adam Caldwell's along to discuss, but I notice he's not here at this moment. I'm just making contact with him to see if he could join us. Sorry, Derek, do you have any further information?
Adam did indicate that he potentially would be unable to join till about 11:25, 11:30ish due to diary demands. I would perhaps suggest, Chair, we could take item 11, which is the additional item that was circulated late.
Yes, that's the finance paper. Yes,
that's it.
Sorry. Yeah. Yes, I'm sorry about that. So that'll probably take us to when Adam can join us. That's fine. Sorry, this is the disadvantage of not using one screen rather than having two screens. Okay, so item 11 is the finance paper, which was circulated separately as a late item. So over to you, Alex.
Thanks, Chair. And typical, the doorbell's just gone and the dog's going mental. Sorry about that. The report you've got here today is an update, and I must apologise for the delay in actually getting that to you. It is still quite tight to be able to turn this round within that period of time. So that was the reason for the short notice around about the report. And I know that the IJB was keen to see this report, which is why we made the effort to try and get it here. I think what we've kind of seen since the last time we met is that we've seen some funding that's been allocated. So we've got clarification on the funding levels that have come across so far. Within that, the funding was allocated on a formula basis, but as it stands and based on the information that I've seen, we don't have any particular implications as a result of that funding being allocated on that basis. That seems to have met our requirements. There are 2 or 3 areas though where where decisions are still to be made, and that's around prescribing and also around about the funding to the GP practices and also the funding on unachieved savings. So there are 2 or 3 areas there that the Scottish Government's still working on, and we need to be mindful of that. There is reference made within the information that came across that should there be an issue with regard to the funding that's come, then there's an open door to further conversations about funding around about the COVID response. In terms of our financial position, it largely stays the same as what was reported at the last time. There have been some minor movements, but the movements that we have seen are in relation to the care at home contract, which we discussed at the last meeting of the IJB and the increase in demand for care at home services. And then the other area is regard to prescribing. So both of these areas I've added onto our most recent version of our mobilisation plan. And I'm awaiting information from the Scottish Government about whether that will be funded or not. I suspect there will be something. We should start to hear information over the next 3 months around about that and see where it goes from there. In relation to the finance itself, is that I guess one of the things that I've said is I've probably been pretty prudent in terms of how I've forecast, particularly in terms of any offsets or areas that are likely to underspend until we find out what's happening with the whole level of the funding. So I would expect in January, and what I'm going to encourage the accountants to do for the end of December's monitoring and reporting in January is actually to go through the monitoring in a lot of detail so that we can nail down that forecast at the end of January and we know where our financial position is at that point in time. I'd highlight to the board that we still do have a small reserve which is able to offset any financial pressure which isn't funded, and you know that's been consistent throughout the financial year. In In relation to Appendix 1, we've seen some movements in terms of the period to date and the period actuals, and there's some fairly major variances there that we're investigating. And my feeling is, with regard to that, is one of the difficulties is the unachieved savings and how that reflects within there. So I'm not surprised to see some of these variances moving like that. But what I need to now do is to sit down with the team, as I say, and really go through that in a fair bit of detail. The other area that the other thing I would mention is that the profiles and the profiles that we've typically used are probably not, not as reliable as they could be in relation to this financial year, given everything that's happened so far. There's one other little bit that I would draw your attention to, and that's in regard to the mental health services. And we seem to have some more spend on methadone, and that's something that's being investigated by colleagues within the Alcohol and Drugs Partnership and the pharmacy services. I think what we're seeing, we suspect this is a miscoding rather than additional expenditure. So, but we are doing some investigation around about that to determine why that's happened and what any corrective actions that we need to take. So as it goes, Chair, we're in the same sort of position as we were in September. The forecast remains largely static, and we've got the pharmacy and the care at home, which are new things which we're looking at and trying to deal with. And as I say, we've put them on the mobilisation plan as it stands. Chair, I'm happy to take any questions and from the committee.
Thank you, Alex. Questions? So John Cook first.
Thanks. Yeah, it's just on the increase in prescribing costs. Is that basically GPs still prescribing what they've always prescribed before? Well, it's to do with the wholesale price of generics fluctuating through either supply and demand or currency fluctuations, or is it a change in the mix of what GPs are prescribing and maybe using more modern, more expensive stuff?
My understanding is, Councillor Cook, that this is there hasn't been any change in what the GPs have normally done, and that it's in relation to the cost of the drugs that are causing the fluctuations as it sits at the moment. I think one of the issues that around about that movement is whether it actually all relates to COVID or not. So when you look at that, and from my perspective, I sit back there and say, well, it wasn't like that before, so what's changing the system? Well, COVID's changed, it must be in relation to that. I suspect there'll be some detailed analysis done at a national level about how these costs have moved, because if you consider in terms of pharmacy, our pharmacy budget, I actually expected our pharmacy budget to underspend this year because of changes that were being made to the tariffs, and that would have provided a benefit during the year. Well, what actually was seen as an overspend on the budget as a result of that. So what we now need to do is to get to the bottom of that and provide that information nationally and wait on and to figure out what's going to happen and whether the Scottish Government is prepared to provide additional funding for that. But the demand seems to have now levelled out. I would say the demand, or the amount that we're supplying, seems to have levelled out, and it's back to nearly normal kind of levels. But the worrying thing is the unit cost, and what we're now seeing is that cost, the unit cost across the whole financial year.
Thanks, that's me done.
Thank you, John. John Tomlinson now.
Thank you. Just three questions on page 16. I think this is just a minor, but just to clarify, is that figure, in fact, just a typo in terms of the IJB? Is that just carried forward as the ACC figure, and that, in fact, it should just be the, or not?
John, I think what's happened is that table split over 2 pages. So on the other page, there's a is that what you mean? So on the other page, there's a column which is really the total of the ACC and NHSG funding.
Okay, right. So that's what
37.8
funding. That's fine. Yeah. Okay, yeah. So substantive point more, and probably just to recap on this, I suppose, the extra monies for COVID-related costs, of which 5.369 due to come from the Health Board. Is that for the full year, or is that for the first part of the year? So I'm just trying to square that with the 10 million or so. Well, it's 11 million for the first half year, and I'm just, will we be seeking more direct costs as well, or does that 5 million cover it all? So it's just to tune into that again, please. And then my third question was around the older people's budget, and just to understand if I'm reading it right, this is on page 11, 4.2 million over budget in the first half of the year, but that coming back to 1.1 over the full year. So it's just to understand why. I mean, it's good if it does come back in, but it's to understand what the basis of that is. Thank you.
So the direct costs of COVID, they haven't been distributed for the full year yet, and what we've seen there was two different mechanisms that were put in place, one in regard to social care and one in regard to the NHS costs. And I think what they did do was they took an estimate on the NHS side of, I think from memory, I would need to go back and double check, but say it was 70% of what was in between 2 and 4, and there was a different formula used for the social care side. So I am expecting more money to come in around about the direct cost in January, and that's certainly something that we'll be working on. I think what I've said, and I've been clear when I've spoken nationally around about this, is that these costs will continue to move because the costs are how would you say, the costs are continually, shifting. So, for instance, if there's an extension in the social care sustainability scheme, well, at the start when we first estimated our costs, we were just, we had to just basically estimate them without actually having any data there. Now we've started to get some data. We'll have a better idea of what this cost of this social care sustainability scheme will be across the whole financial year. But certainly, at the outset, I had put in figures for the whole financial year. Whether or not that they come true depends on the rules that are in place at that point in time. And with regard to the NHS side, I think that, again, we will see some movements in these figures, and that's one of the reasons why I've tried to keep the figures as close to the same as possible, because when we go into a second wave, we don't know what that's going to bring, and whether it's going to be the same as the first wave or slightly different from the first wave. And that's one of the things that we need to start estimating and thinking about. So certainly I'm expecting additional funding to come in around about these sort of things. And I think what's happened and what the Scottish Government's doing is they're not providing us with all the funding until they see what our financial position looks like, because they don't want to put a lot of money into the IGBs and then they end up with major financial reserves as a result of that. So I can understand that, and that's why I think when we get to January, that will be the critical point for us in terms of what's actually happening as a result, where we actually stand. In relation to the other bit, I kind of touched on that in my introduction. I mean, there's been a number of movements around about there, John, and you can see that the other ones are actually under, and across the whole of the council side, the two of these, all the variants just net off or nearly net off around about there. We'll be doing a deep dive into that budget. And some of that will be in relation to the savings that have not been achieved, which have been coded against that older people's budget.
John, are you happy with that?
Yes, okay, thank you.
Okay, great. Luann?
Thanks, Sarah. Two questions, Alex. One on 3.10, it talks about ring-fenced funding, Action 15 and PSIP and ADP. Could you just tell us a bit more? I mean, are we going to get the funding if we spend it? Is that essentially what's happening? And if that's the case, are we maximising what we can do around, bringing forward activities so that we can get that funding into our communities? That's my first question.
Yes, that is a new development since then, and you know, I think at the last time we reported, this information was just starting to come out, but the allocations have been confirmed, and my understanding is that the funding that we hadn't spent in previous years around about these will be available to us if we can spend it. So that's a positive. I'm still waiting on official confirmation about that from around about ADP, but the rest of them, that's my understanding, and that's the basis that we're working to. So I think you're right. The Scottish Government has basically said if you can spend it, then it will be there. From our side of things, we're looking again at PSIP, and we've got a couple of reports on Action 15 later on today's agenda, and I know that Simon's doing work around about the alcohol and drug stuff. So we are working on it and seeing what we can do to move these projects forward as quickly as we can do.
Thanks, Alex. And second question is on GMEDs, still reporting significant overspend. Is there a plan in place to look at the redesign of GMEDs with timescales? And I know it's a hugely challenging area, but I'm thinking beyond this year, it's really important that our hosted services are looked at and redesigned appropriately. So I just wondered if there was a plan with timelines specifically for GMEDs at the moment.
I would need to refer to Sandra to see if there was a plan, but I would say just before Sandra comes in that we've got an underspend on our hosted services of nearly £600,000, which is the first time that's ever happened. So whilst GMED's overspending, the rest are coming back in, and it's really good to see. And it's some of the work that's actually been done in relation to the response has helped to reduce some of these costs. So pleased to see that. But yeah, I'll pass over to Sandra for the GMEDs question.
Hi, yeah, just to say that there is absolutely a plan in place that was presented to us last week through our leadership team. There has been they're looking at a redesign, a review of the areas, and that's just getting worked up just now. And I think they're also not looking at bringing in savings from there. I feel that the plans that they put in place will bring us much more in line with the financial envelope that we had for GMEDs. So we're working with them to move that forward, but definitely a plan in place with timescales, and they're hoping to have that much more stable workforce in place by Christmas time, by the festive period, as their working timetable. So we hope to see some real change in that over the next few months in practicalities, and then financially moving into the new year. Okay.
Thanks, Sandra. That's really good to hear. Thank you.
Okay, I don't see any other hands up, so we'll go to the recommendations. So we're being asked to note it, and we're being asked to approve the budget environments in Appendix F. So we're content to do that, Alex?
Yeah, Chair, I was just going to say just before you finished, and yeah, I'm happy with the recommendations if the board are, but I was just going to say there is the option to have that special meeting if new information comes to light. So just want to really highlight that to the board, and that, you know, given the fluctuations in some of this stuff, that we might need to report at short notice, and we will do if need be.
Yeah, okay, no, absolutely. We know it's a constantly changing landscape on finance. So yes, if we need to have a special meeting about it, we will. Okay, so we're noting those recommendations. Right, we're back to where I thought we were 10 minutes ago. We're now on item 12, which is NHS Grampian Renewal, and we're joined by Adam Caldwell. So welcome to the meeting, Adam. I'm glad you were able to join us today. Would you like to speak to this paper, please?
Yeah, thank you very much, Chair, and apologies if you changed. I was in your city strategic multi-agency group, and just as it was finishing, I saw a text from Sandra saying you're on next. So apologies, I didn't see that, or I would have popped out and come to join you. So apologies to mess you about. So thank you ever so much for the invitation to come and meet with the Integration Joint Board. Just a tiny bit of background. So in the summer, NHS Grampian Board, the formal board part of NHS Grampian, convened a short life working group to look at renewal on the back of COVID. And we were joined by Sarah as the chair of your IJB and chairs from the Shire and Moray IJBs as well. And the group met on 6 occasions, and we're trying to think about what were the really key strategic issues that we could take forward to make a difference for the population as we you know, we're learning from COVID. I was going to say coming out of COVID, but obviously we're still not doing that yet. So it was really at 3.3, just a summary of the 4 things that were the key big themes that came up, was this idea of people-powered health and care. So that's very much about this transition of power to people. So, you know, really good thing. The second part, B, was this idea of the enhanced North East collaborative leadership. And I think that's what I probably want to speak about quite a lot. Number C was the reducing inequalities. So how do we level the playing field and reduce inequalities? And the 4th one was about looking at digital opportunities and working together. So trying to tie together a couple of things. The group were really considered about how we take this forward with partners, because lots and lots of it to be successful needs to be with partners and with partnership. And the group were really sensitive to the idea that if we appear with the report as a da-da, here we go, it feels like it's not a partnership. You know, it feels like it's kind of come and it's being plonked on to any group, be it an IJB or a community planning partnership or any of these really important things. And so I'm here just to really start that bit of discussion about how we can work together as the integration joint board with health. And there's lots of things here that we can do. I think if you're a member of the IJB as an elected member, I think there's something really exciting about how you penetrate into your council organisation and all the networks you have in your communities. Some of you will sit on the community planning partnership. So how do we start to think about that? So I was hoping I could frame it. I hope I've done that okay, but framing it that we're not saying this is it and how to do it. We're saying we think these are really important things that we would probably all like to get around. And therefore, at the sort of start of that, how do we do that together and how do we push it forward? If I could say one more thing, Chair, sorry, I'm probably speaking longer than you'd hoped. That one of the key things within it is about this idea of being an anchor organisation. And I think that's probably one of the really strong things that we could work together on, to think, what does that actually mean? What does that mean we have to do in behaviour terms? And, you know, in the Appendix 2, there's a suggestion about the sort of 5 things that might hold us together as anchor organisations, sorry, not hold us together, allow us to be anchor organisations. And those are about how we employ people, how we have a sense of place, how we procure things, how we have buildings and presence in places. And so I think if we could, you know, if it's an attractive proposition for all of us to work together and to think about how we might all be anchor organisations, I think that could be the start of, you know, a really quite a considered bit of work over a period of time to think, how does that have an influence in the population and how do we have a real presence that makes a difference for people's outcomes? So that's just by way of introduction, and obviously happy to expand on any bits if anyone's interested in them, or to think hopefully about how we can, I hope, take this together, forward together. Thank you very much, Chair.
Yes, thank you, Adam. I mean, I'd say it's one of the most interesting things I've done as chair of the IJB is participating in those 6 sessions. They were really interesting, thoughtful discussions. And Luann and John contributed on a couple of occasions in wearing their NHS non-exec hats. So it was a really useful exercise, I think. And for me, it highlighted actually a lot of the similarities of approach that we have across Grampian. So nobody came at it from a completely different angle. We were all coming at this from the same approach. I think there were slight differences in how we take it forward, and that's reflected in your paper. But I'm very glad that we're discussing this today. So over to everyone else to make some comments. Maggie, nice to hear from you. Can you go?
Hi, thanks very much. I actually, when I was reading it, I found it really exciting and interesting to read. I really feel that it touches very much on all the other discussions that are going on at the moment around COVID and nationally. The Social Renewal Advisory Board work that's going on is very similar in lots of ways in the ambitions that it's talking about, as with this paper. Obviously, my third sector hat is firmly on my head, and I feel a slight presence of my Grampian TSI colleagues with me as well in spirit. It's really just to sort of raise that as a major source of resource and help, because this issue about wanting to capitalise on the wonderful opportunities and the work that's been going on has to be framed, and I'm sure this has been discussed, but I feel I have to say it has to be framed in the context of the real world for the third sector. And the real world for the third sector is that we are extremely reliant on temporary, time-limited, gradually reducing funding pots that need to, and that is an area that really needs to be addressed across the third sector, especially if the drive and the desire is to pull in more resource to rebalance the care as this paper suggests. And it was really just a plea for using our third sector interfaces as well as we can, but also considering the resource requirements to enable the third sector interfaces to join in and pull in third sector. So it's a two-layered point, which is you have third sector interfaces who are able to reach the sector and able to reach the sector well if they are well enough resourced. But you also have to address this crisis that we have at the moment that's going to be ongoing in the third sector, that in order for us to do what we want, and we all do want to do this, we have to address the funding issues that third sector are really up against. So it's really just a bit of a plea, but I do like the paper and I do like these discussions, and I think these are the right discussions to be having at the moment. I just hope that they are surrounded by a nurturing environment for those people to be part of them properly.
Could I make a comment on that? Is that okay? Thanks. Yeah. Thanks very much, Maggie. And I'm glad the paper lands in the sort of right place. So I think the sort of two bits before I come on to the funding part of your question. If the anchor organisation bit works really well for us, I think the third sector have two key components there. I suspect some of the larger bits of the third sector could absolutely be part of that anchoring organisation. And I think at the other end of it, for, on the spectrum of people who are part of the third sector, for some of the smaller, more local organisations that deliver good, really great services and support for people, would absolutely help and be supported by the anchoring of some of the bigger institutions. So I think there's a really nice bit where the third sector would span probably across the spectrum there, as you do for so many things. In terms of the funding, I think that's it's a well-heard point, very aware of it, both the infrastructure part and also then the delivery level. That's not something I can make an easy response to, but other than to acknowledge the awareness of it. And I know through, the Chief Officer, through Sandra, there's a real awareness of how we work with it, how we commission things and how we do things together to make progress. So there is a real awareness of it. And it's something we need to work on together, because the third sector does deliver, so much, both in direct provision and in the slightly wider sphere of improving the health of the population.
Alex, did you want to come in response to Maggie and Adam just now, or is it a separate point? Yeah.
No, it's in relation to that. It's in relation to the funding, Maggie, and I know you'll already be around about this, but I guess that's something that should be maybe fed back into that adult social care review and the issues that you're highlighting there. So I know the chair and the vice chair will be mindful of that already, but I think at the outset they were asking for that, and certainly some of the conversations that I've seen being had around about that, the third sector has mentioned, and that would be a useful in around about what is a national issue around about the funding of the third sector.
Yeah, We'll the meeting next week will certainly make the point about funding and the fact that things have got to crisis point for a lot of the third sector with the additional pressures for that COVID has caused, because you're an essential partner in delivering our services. So it's in everybody's interests that the third sector is stable and sustainable as far as possible. So Leslie Dunbar next.
Hello. I'd just like to say to Adam that I really welcome the paper and the approach that's being adopted. I'm not going to go over it anymore in terms of resource, but I think that there is a kind of key issue around if we're looking at seriously doing a kind of people-powered approach where we do have to be aware of maybe smaller local community groups and the kind of important role that they play in local communities, and how, if we are going to utilise a community development approach, that we need to look at how we build capacity within those organisations to help them better connect to the kind of wider networks that are available and that they are certainly part of, but then I suppose fundamentally how they connect to the wider organisational networks. I'd just like to get some comment from you, Adam, on that.
Yeah, thanks, Leslie. Yeah, I think that's just a really well made point about that. I think in my mind, I'm seeing a sort of a grade of what we need to do, and if we want to make communities vibrant and able to be as self-sufficient, self-managing as they can be, then that investment's going to be critical in how we do it. So again, I think, through all of our public sector organisations, we've got lots of examples of small attempts to try and really create capacity in communities, and somehow I don't think we often translate that to then doing it really well at scale. So that we get the impact of scale. Obviously, it still needs to be done very locally, and I think that's part of our challenge going forward is how do we actually do that. So again, I think a number of things in the paper aren't particularly new. We've tried to put them together in one place, and it's something about how do we turn those to actions and develop that momentum. So I think a really key bit of the recommendation B about how all of the public sector and third sector organisations in the North East work together is to draw on the aspects of everyone. So, council has, a huge impact in the city plan and through the all of us through the CPP at the city plan about how we, do things with different communities and create a vibrancy. So I think it is that bit of making sure we come together and we get a really cohesive, joined up approach. And the integration joint board, again, spanning two big organisations with lots of other expert advisors on it. I think if we can tease out over a period of time, how does the IJB agenda sit alongside some of these key facts, suggestive factors, to then help build that momentum over a period of time. So I think none of these are quick fixes either. I think they're all things that we'd expect to take forward over months and years to have a really big impact. But I take your point totally, Leslie. Absolutely, local developing momentum is essential to achieve the outcomes.
Okay, thank you, Adam. I suppose in a sense it also leads to the whole issues around parity and health inequalities as well within communities.
Yeah, absolutely agreed. So the inequalities, we've got a number of fairly tangible things in there. They're all fairly simple things apart from the anchor organisation. And I think the anchor organisation, the evidence base for making a change in inequality is reasonable. And so I think it's something that if it seems like a good idea across all of the agencies, that we should really get behind together and see what are the things that we all do that contribute to starting to make a difference in the or to continue to make a difference in the inequalities arena. And again, we certainly know our areas. We have very good intelligence around where we have high levels of inequality, and what might be the things to address them have to be multi-agency, and as we know, are quite complex to progress. But I think that, you know, we're at a moment, aren't we, where, as Sarah said in her introduction, COVID's given us some more exacerbation of inequality. So it's just absolutely essential we get a joined up approach and get right after it together, or continue to do it, because it's not that we haven't done it before, but with a renewed vigour.
Thank you, Adam. I look forward to future reports.
Good, thank you.
I have Luann and then John Tomlinson.
Thanks, Sarah. Really enjoying just hearing the conversation, and that I think what strikes me is that this is stuff that's already happening. We're already doing a lot of this work, but the challenge is probably how we can do that more collaboratively across the Northeast, rather than it being City, Shire, Murray doing their own bits, and what could we do to bring that together, totally recognising though that the solutions are local, but maybe the outcomes can be Northeast, and the language we use maybe could be a Northeast language rather than being so separate. So I'm keen that we look at, are there any concrete things that we could commit to now that would help us just progress and develop in a Northeast collaborative way? So the type of things I'm thinking are, is there an appetite for getting a Northeast collaborative group together, including third sector interfaces, of course, and all the other partners, to discuss, well, what is an Anchor Institute? And when the city talks about that through community planning, what language are they using? I think they're probably calling it something different. Health uses Anchor, and trying to just develop a bit more of a shared understanding of what we're all doing. And then hopefully by doing that more collectively, there could be greater impact. So that's kind of one thing. And we did have these Northeast groups before. So it's a question back really, is, would people come to that, mindful of everything else that people have got on, but is there an appetite for doing that across the Northeast?
Yeah, I think what we've learned through COVID is actually coming together is remarkably easy and quick and efficient now. Whereas, when we did it before, everyone had to travel somewhere, didn't they? And we tried to get together, and it felt like it took up lots of your day to do it, which I suspect made it more challenging for people. Whereas I think you could come together very easily for an hour now, and it just takes you an hour, doesn't it? So maybe there's an absolute opportunity to try that. In terms of the Anchor organisation, that's been one of the key things on my mind actually, and I've been speaking to the university, the Aberdeen University. I do all sorts of things with them, and they're having terrible challenges with some of the final year student placements around normal things because of COVID. And so we've got lots of people with lots of brain power to help us try and think this. So I've been framing the question whether we could get a couple of final year students to come and do some of that initial help to think about, and then draw on the bigger group. So I think we're in a similar page, Luann, about what we might draw on to do that, because I think the Anchor organisation could mean, any number of things within those big headings. But we need to figure out, if we think it's a good idea, how do we make it ours for our area and for our patch, and really take it forward. So yeah, absolutely. I think that's a good thing.
Thanks. And the other kind of thing I think as an action would be and I suppose this is a question to Leslie and other local authority folk on the IJB, would you be interested in, if the NHS committees were more open for you to attend, would you be interested to come and hear, say, for example, performance governance at NHS committee looks at the whole system, waiting times and financial overview and all those type of things, and maybe we need to start working less in our silos in our different organisations, but be more open to other people coming in and getting that wider perspective. So that's just a random, and it's not, it wouldn't be for me to open up all the committees for everybody to come to, but as a principle, would that be something that might be helpful, or is that, or not? Don't know, Leslie, if that, like performance governance at the NHS would link very well with clinical care governance at IJB. Would that be something of interest to you, if that was possible?
Definitely, yes.
Okay. Okay, so that's maybe something to think about. Mm-hmm.
And maybe we could have a, like a further discussion, like offline.
Yeah. Okay, thanks. It's really helpful. Thank you.
Good. Okay, John Tomlinson, then John Cook.
Thank you. Yeah, I was also like Luann thinking, okay, what does this mean in practical terms for us? And so I'm conscious that as an IJB, work is now starting to look at the revised strategy for, I think it's April 2022. So the next 18 months is important time on that. And then NHS Grampian is looking at its clinical strategy as well. So it strikes me that conversations around these two things should pick up these themes, and also what it means to be system-wide. I mean, I'm relatively new around both of these organisations, but impressed by the level, the strong relationships that there are. But I think what this is opening up is how we take that to the next levels in practical terms. We've talked about the third sector and, getting capacity in there so that if prevention and early intervention is going to be real, it's not just done on a whim of, hoping somebody's going to pick that up. There needs to be some infrastructure that's funded around it. So I think those two strategies needing to be reformulated over the next 18 months. So it's really a question to Sandra and to Adam, who both hold those two different things. Can those both be taken forward with these themes in mind?
I'll take Adam first and then Sandra to reply to that.
Thanks, Sarah. Thanks. Yeah, thanks. Absolutely. So I think the part of the spirit of the board's renewal group was to set a real frame for further thinking and development. So it was trying to just set that frame, I think. So as we develop the clinical strategy, it will be essential we're doing that together. There's no sense that we want to develop the next iteration of the clinical strategy in isolation at all. We want to work with all partners to do that, and we're keen to do that from the inception point. I think last time I think we involved people really well, but it was probably more like a consultation point rather than from the inception point. So the idea this coming time is to involve much more broadly from the inception point, John. So absolutely, and these themes I think are really key to us taking forward for sure.
Thanks.
Sandra, over to you.
Yeah, thank you, John. Just to clarify, I suppose the paper that is coming forward, I think that's going to community planning, as well as the one that it'll either be December or January for the IJB, really highlights how we're working to fundamentally, I suppose, towards our holistic communities and moving forward for there. We're also very mindful of in moving forward the strategic planning, that it's much more about co-produced, and our colleagues across NHS Grampian, our third sector, our communities will all be round about that and firmly across with our council partners as well. I think one of the key things from the strategic plan previously was that the IJB strategic plan did fit into and dovetail into both the clinical strategy and the LOIP. And I'm really mindful as well that another, I suppose, a key determinant which Adam will obviously be aware as well, is that the LOIP's due for a refresh within Aberdeen City as well. So we've got real opportunity for synergies right across all of these systems. And I think I would just agree with Adam that I think we are in a position whereby there's a very collaborative focus, very much on co-design and really understanding the impact of that whole system in the Northeast, as well as being as local as possible, but as as specialist as needed. So,
thank you, John Cook.
Thanks. Yeah, just kind of picking up some of the themes that we've already started to discuss. I haven't really thought this through as an idea, but in terms of reducing silo working, could we hold a briefing session or a workshop to which we invite all elected local authority members, maybe some community councils, maybe some officers from the local authorities? Yes, if we did it Grampian wide, you might have a kind of a cast of thousands, but so I haven't really thought through all the logistics of it. But when I was reading the paper, I was kind of nodding, oh, that's good, that's good. I'll say to my colleagues, you really ought to read this paper, but actually getting them on something like this, and I would say maybe doing a workshop that might help to get down the side, get some of the silo working. As I say, I'd not really thought it through, but just an idea.
Yeah, John, thanks very much, and I'm glad you nodded as you went through the paper. That's very encouraging. Yeah, I mean, I think that there's something about how we get lots of people engaged and really thinking about this. So we did a session, I think at the start of the week, about winter preparedness. So it's a slightly random thought, but it ties together in a second. And one of the key bits of that is absolutely about trying to have a much deeper relationship with all of the elected members, not just the people we'd come through normal groups, because again, the strength of councillors is enormous, and we've seen that through various bits of the pandemic, where actually that relationship with local communities works so well through locally elected members. So we're really keen to develop that. So absolutely yes to what you're suggesting. Again, don't know, we'd have to think through how we do it, and again, we'd take a steer on people coming together from City, Shire and Murray. My experience of that is some people are very happy with it, some people are less happy with it. So we just need to try and find the right balance, or maybe it's the right topics where it's really appropriate that we're together, and where it's different topics we're really clear it's a city issue or a Shire one or a Murray one. So, but again, with the chair, we can get some steer on how we manage some of that sort of potential sensitivity as we work across the big area to get the most from it.
Yeah, and I think it's a good idea, but we need to be careful how we do it so it doesn't become unmanageably big. And I keep coming back to we're trying to do an awful lot more on a locality basis. So we've operationalized services to localities. We've got locality engagement groups, which I'm really excited about. And we had a lot of discussion, and quite a difficult session, I remember, about comms, about what we mean by communications from public services out to service users and the public. And there were lots of different views on that, and some very strongly held views about whether we're doing it right, whether we're getting the tone right, whether what we communicate is appropriate. And actually rethinking how we communicate with people and using localities, and kind of discussing the themes in this report through our locality engagement groups might help develop a consensus about the way forward, and actually helps us change the culture, not just of staff, but of the public who are using our services, and getting them to understand the modernisation of a lot of the services. We struggle sometimes with that when we're changing services, and actually that's because we're not communicating why we're doing it properly and involving them properly. So I think that's also part of being an anchor institution, is modelling change and leading the business of change, I think. So I agree with doing everything locally as much as possible. I agree with involving local people. And for me, the big light bulb moment was when somebody in one of the groups said, this is about changing the power relationships. And it absolutely is. And I think if we can all remember that and take that forward when we're consulting on our strategic plan and the clinical strategy, when we're working with our locality engagement groups, when we're drawing up our new locality plans, which we have to do, that's a really big opportunity to also embed some of this work. I think we can make progress on it, because I think there is actually a lot of consensus about where we have to go. Just we've not articulated it before in this way. I think I would like to make a request, actually. I've not discussed this with anyone, so this is why I'm a bad chair. You should never do this when you're a chair. You should never just spring things on people. But I think I would like our locality engagement groups to see this paper as part of the work that we're doing, because these are people that are really interested in health and social care services. And it might spark some interesting discussions with them about co-production of the plans and the services. So could we do that as an action from today, as one of our actions for taking this forward? Anybody got any views on that? John, and then Sandra. Sandra might tell me off now.
Yes, but I can, my mute buttons work. Yeah, I think that's a good idea, and it would be good to hear what they're saying. I assume that was implicit in what you were saying, but yes, to get feedback on that would be great.
Sandra?
Yeah, I can certainly pick up with Adam, and we could look at how the paper could be shared and how that can be taken forward. So I could pick up with Adam offline, and we could see about that, because we've got quite a network and a lot of interest still in our locality empowerment group. So that'd be useful. But I probably, to get the benefit of that and to keep Adam's link with it, might be easier to pick that up.
Yeah. Okay. Right. That's great. Okay. This has been a really interesting discussion. It's been really good to hear people's thoughts on it all. And I'm glad that this wasn't a series of workshops with an output that's just going to sit on a shelf. I'm glad there's activity flowing from it. So I think we've done what we were asked to do in the recommendations. And thank you again, Adam, for coming along. I know how busy you are along with everyone else at the moment.
Thank you for the invite.
I think for the recommendations, we are asked to consider the reports, to consider how we might want to work with NHS Grampian on the key themes, how we can influence our wider networks. So I think we've done all that, and we've come up with some suggestions for how to take it forward. So that'll be recorded in the minutes, and I'm sure we'll come back to this. So thank you again, Adam. It's been really, really good having you along. Right. I just wonder, we've been going for an hour and 45 minutes. Would people like a 5-minute break before we take the daycare paper, or do you just want to plough on? I'm in your hands. Not bothered? Okay. We've had Anne sitting for an hour and 45 minutes. So let's take the daycare paper, and then let's take a 5-minute break after that before we do the transformation decisions. All right. So Anne, over to you for item 13.
Thanks. I've been catching up with all my other work while I've been sitting waiting, so it's been fine. So you have had before you the paper around daycare redesign and the associated appendix. And I suppose, so within the paper there will be the recommendations. I just thought I would pick out some highlights of the report. Obviously we had we gave a presentation at the members development session earlier on in the month as well. So just pick out some highlights. One of the highlights really around planned respite, because I know that has been of particular concern to members, and just the associated level of stress and distress for carers with the absence of planned respite. And the fact that there was a decision made not to mobilise any daycare services at an earlier report. So that this report does advise that wherever possible, where the provision of of care has been made for people based on the level of complexity and the level of that distress, whilst at the same time reminding us of the ongoing tension between keeping people safe from the transmission of COVID and balancing that between the level of distress. I was asked to pull some numbers for members for this committee. So it was just to confirm with people that from a learning disability perspective, in last year we provided 2,097 nights of planned residential respite for people with a learning disability. And between October and March, we're planning 800, which I guess if you think about that, that equates to 1,600 nights of residential respite. So that's a significant reduction from what we have previously provided. And for older adults, typically we would have had 127 clients who would have required planned residential respite, with 5 of those people requiring 5 or more weeks in a year. And what we have established, or what just to reiterate, that for those people who've been presenting with the most significant levels of requirements or the most significant levels of care stress or distress, we have been providing residential respite in some of our community facilities. You will also have within the report a summary, or as an appendix, a summary of the consultation that we have conducted since the last time I was with you. And that's both with the current providers and with service users. I guess the context of that consultation has been, what we have to remember is that we're making significant changes in other parts of the social care delivery system, particularly around care at home. So I think there have been some really strong themes that have emerged through that consultation, but some of those I think have been conflated with confusion about at the time about who was going to be providing care at home for people. Obviously, our care at home contract goes live on Sunday, so I guess hopefully so a lot of those questions have been answered for people. Our learning from this has been that going forwards, I suppose what we are going to be trying to do in particularly next year is we've had plans around how we plan our commissioning of activities more carefully, so that we're not compounding lots of different changes on our frailest people within the community. There are key themes that have emerged from the consultation, and we have pulling those key themes into a draft implementation, which you have with you. And I have to stress that is a draft implementation plan. We have plans in place starting from tomorrow to pull together a group of people to form an implementation oversight group, and there'll be associated work streams that will progress this piece of work. And it is an ambitious plan. You do have within there, though, what we would regard to be our priority areas for consideration and the suggested timescales around that. There is a general update about the support that we have made available to current providers and we continue to work with them closely. But there's also a specific update on the James Tyrrell Centre, which is advised it will no longer operate from the 31st of December. And within the report, I've worked with Rose Clayton from the James Tyrrell Centre around the wording within the report. So the decision that has been taken, it's not been taken lightly, and Rose has obviously has significant concerns about the members that they've been supporting. But the decision is around the consolidation of their church estate as well, and COVID obviously has added to that decision. But for members to note that Rose feels that they've worked really closely with our health and wellbeing team, and she's satisfied that actually with working with the health and wellbeing team, she's able to continue to provide support for those members in a far more organised way than she would have done previously. And I think that's all I really wanted to pull out of the report. I'm happy to take any further questions that people might have.
Thank you, Anne. So, questions from people? John Tomlinson.
Yes, thank you, Chair and Anne. The principles of this are really sound and welcome. And in terms of there being people in the community where we're trying to get the early intervention aspects in place and the prevention, so that we're supporting that. That suggests to me that we, a bit like the conversation we've just had around the third sector, around renewal, etc., there needs to be an aspect of infrastructure put in to help that, although you try and keep it light. So potentially we're spending a bit more, but saving money in the long run because people become more resilient, if I'm understanding the model right here. So, and one thing that the public can sometimes look at in terms of change is that it's really cost saving. And so I'd just be interested what our handle on this is in terms of our net spend around this currently, and what it will be in the future in terms of what the change looks like. So totally support the model and the way this is going, but just interested in where that funding bit comes for us.
Sorry, so we know how much we spend on our commission day services, and off the top of my, I do have those figures. I'm just trying to work it out in my head. It's over £200,000 that we would be spending on some of our commission day services. There's obviously an amount of money that's tied up within our service level agreement for Bon Accord Care, because they're one of our commissioned providers as well. There's also within that, there's the residential respite that we have had for older people has been tied up within Rosewell, but part of our consideration for going forwards would be to work with Bon Accord Care to see if they could provide capacity for residential respite within some of their other facilities. And I suppose that's the conversation that we need to have around with them around how we provide that. There's also, what's quite difficult to extract is that there's a lot of people who receive one-to-one support because they don't want to go to a day facility. So, and that's always been quite difficult for us to extract the exact costing of that from when we've been looking at our data. I can see that other people want to come in on that. Maybe Sandra's got more that she would like to say.
Yes, I can. Sandra, do you want to come in? Yeah.
Yeah, just really to add, I think that you're absolutely right, John, that sometimes that people can believe that it's down to cost, and that's not really what we're looking for here at all. It is much more about moving towards the early intervention, and it's putting in place the correct model. And I think, as Anne suggested in our implementation plan, there will be a programme management approach which will go in place, which will clearly outline the benefits of this, and there'll be a benefits analysis about what will be brought forward. So that whole package round about the funding, what's in place beforehand, and any additional spend, where the resources will go, will all be part of that programme approach. So it will be robustly looked at as to how we can, about how we move that forward. Hopefully that's helpful.
Yeah, thank you. I think us seeing the transparency on that will be good. And then in terms of how we position that, if you like, with the public and with groups, because people don't like change quite often, and the fact that we cover that, plus we get a more robust and meaningful model which moves us on the intervention and prevention, I think will be good. But so transparency on that's ideal. Thank you.
Yeah, and I think that, sorry, just to come back on that, if that's okay, Chair, is just to say that the benefits realisation as part of part of our programme management approach definitely will help clarify that and keeps us on track and keeps coming back to that. We'll find that beneficial in other programmes. So hopefully that, and once we've got that is transparent fully.
Yeah, thank you.
And that will come to your committee role, John. It'll come to risk audit and performance. So that's good. Okay, see Leslie and then Luann.
Hello, Anne. Excuse me. It's not really a question. It's more a comment in terms of, like commending yourself and, the team of officers that have been involved with this particular model, and also the approach. I think in terms of, that you've dealt very well in the report around maybe some earlier concerns in terms of the transition and I also welcome the co-design approach in terms of, you know, also including carers.
No, thank you. I think that's where the real value comes, isn't it? In that approach, that's where you learn a lot more than you would have previously considered yourself. So I think it's, well, and just to reassure people that we need to progress in that way. I think residential respite's a really, really good example about how we commission that going forwards, because what we know is that at the moment people are worried about either themselves or their loved ones becoming unwell. So what we don't want to do, we need to understand what people are prepared to accept just now, or what would meet their needs, but also keep them secure in knowing that both themselves and their loved ones are going to remain well and free from harm due to COVID. So I think that's a really good example where we need to continue to consult with people and include them in our discussions about what we commission going forward. So thank you.
Thanks.
Good. Right, Luann.
Thank you. Apologies if this seems repetitious, it probably is, Anne, but I just want to kind of clarify. I really support this direction of travel. It's really important we're doing much more early intervention and outcome focused support for people. I suppose I think it's very, what you've said is in the report, we're heading into a very tough winter for people, and I'm assured, like what you've said, and I just want to be clear that I'm understanding it right. The people that previously would have gone to daycare and would have had regular respite will be supported during this transitional period, albeit in a different way. But there are routes for them to get support through existing providers, and that there will be respite for people that are struggling, because I do think we're asking a lot of families to we're all living through difficult times just now, but it's a long, difficult winter ahead, and just making sure that there is those routes into support to people whilst we get to this more exciting option. Am I right, Anne, in my thinking there?
Oh, sorry, there's a jet just about to go over my head, but yes, you're right in thinking that, and I've sat down with service managers just to go through this line by line, particularly when we were trying to pull together the presentation for the development session or the workshop the other week. And yes, wherever possible, or where people have wanted it, people have been in touch and have offered the support. I think the bit that we can't mend for people just now is that support doesn't look like it used to look like. And I think also, as we went into COVID, there was an immediate, what do we need to do to make sure that people are cared for and looked after? And I suppose that was planned for the shorter term. What this gives us the opportunity is to, because obviously what we know is this isn't going to go away. I think probably early on people thought we didn't know how long it was going to go on for. So I suppose this gives us an opportunity to say, okay, then, so we're here just now. What is palatable to people? What meets people's needs going forwards? What's possible? And we'll hold on to some of because for some people, what we have put in place has actually been really beneficial. They've actually got a longer day, longer opportunities, more flexible opportunities for support. But for other people, it's quite obviously not meeting all of their requirements. And so this is what this gives us an opportunity to do as we go through the implementation of this, is to try and work with people to find something that's a more sustainable model going forward, albeit not going back to what they had in the first place, because that's not always possible.
Yeah, thanks, Anne, and not safe currently either. A couple of points, if I may, Sarah. One is just to note the closure of the James Turrell Centre and the church closure, and I think it would be appropriate, if you agree, Chair, to put on record our thanks for the work they've done over the years, and we hope, wish them well and hope to work with them again in the future, but just to acknowledge that in our meeting today. And I think it's been touched on, but I'm thinking from a service provider point of view for the other providers, and I think Sandra talked about it being a project management approach. So there's going to be regular discussions with them about what happens, what funding they'll get after March. It's not going to be like the 31st of March and they're not going to know what funding they've got on the 1st of April. I'm just thinking of bringing them on the journey and making sure that there's some stability so that they can continue to provide what is going to be needed in this different model. I think that's implied, but just again, just in my straightforward thinking, that is that the case, that providers will be updated regularly and there will be clarity about finance available to them after March?
Yeah, so I can see Maggie's on the call. So we have had one meeting with and it's within the report. We had one meeting with the current provider. So the current providers have been part of our group that's pulled together this model, and we have had one meeting with the providers, and also but in conjunction with ACFO, so that they know what support is available to them. We haven't asked for that funding to be extended, and we don't expect that funding would be extended beyond the 31st of March. I have been in contact with them just to confirm that with them, but also to make sure that they are linking into whichever support is possible. And I suppose our opportunity is, I think the plan was always to try and support people to attend, or signpost people to, a bit like people were talking about before, to try and help sustain those third sector organisations in terms of the footfall that they would have going through them, and some assurance around that. So that's the support that we've been making available to people.
Sorry, Maggie, would you like to come in on this?
Yeah, excuse me, sorry, I had to put my hand down because I had a coughing fit, but I'm fine now, so I'm back on. It was just really to follow up that point of Luann's, and also a little bit about what John was saying, the sort of discussion that we were having in the previous item about this sort of intention to go forward into a more community locality-based work across the board with the Health and Social Care Partnership work and community planning work, and the sort of initiatives that are happening at the moment on the ground in locality areas in different ways, means that there's such a lot going on at the moment for organisations and community groups and third sector in local areas that it is extremely difficult to, what I'm trying to say is seek some clarity on sustainability for those organisations. And although we have offered to support seeking other funding, I think it is, I'm very pleased that within the model that's being described, this transitional period does have some mention built into it, as well as the appendix at the back about all the comments that people have made about some of their concerns around the financial future and how they will manage. I'm very pleased that there is an acknowledgement that there's going to be further discussion on what a financial model might look like. Because as I was saying before, and I do seem to be a bit of a stuck record at the moment on this, but it is because it is actually absolutely important and real. If everybody is going for funding in the third sector because everything is up in the air, then the likelihood of everybody getting funding is extremely low. So in an area like Aberdeen City, where we've got responsibility to look after people, I think we have to look at all the different funds that are on the go across the city, including some of the funds that are administered by the partnership itself or community planning itself, and think about how those funds might be used to help drive change that we might be trying to implement in our communities, pulling the right people in at the same time to have discussions about it. The one concern I do have is if the model only includes self-directed support, there has to be more infrastructure and support around people getting that and done well, because there are reports on that not being a very viable model for the third sector organisations to use, mainly because it is a sporadic and not necessarily very secure model, unless there is more discussion around how that model can be more effectively used so that organisations find it attractive and want to be involved in it. So those are my points, really. I just wanted to sort of pulling on what other people are saying, but as I agree very much with John and Luann, the direction of travel, my concerns are always around where we want to go, very much like John was saying at the start, do we sort of look at whether we've got money to spend to sort of take us on the journey before we save money at the end? And I would like to think that there's some effort going into that around those points.
Okay, I mean, they're comments that we hear a lot from the third sector about sustainability, and there is an inherent tension between SDS and the third sector model as it operates at the moment. There absolutely is that, which is probably why there's been such issues with self-directed support across Scotland. But sustainability for the third sector is also about them adapting, which they are very, very good at, and that and focusing on being person-centered, so providing what people want, which isn't necessarily what they've always had provided in the past. And I think that's what we've learned from the exercise, this exercise, looking at provision of day support, is that it's not necessarily what has already been available is what is appropriate for people now. And I think there's a growing recognition that the offer has to change, but that's difficult. That's really difficult. The transition period of that is really, really difficult, which is why we've got a transition on this until the 31st of March to give everybody a time to understand the implications of the change. So I think the transition period is a really good idea, and I'm very glad that there are discussions going on, but there does have to be an acceptance from providers that they need to change the way they do things as well. And you know, there's sustainability from both ends. There's an obligation on us as a partnership to ensure that services are sustainable, but there's also an obligation on providers, I think. And the person that gets the service user is at the centre of all of this. They're not an add-on. They are absolutely at the centre of all this and need to dictate what is provided, I'm afraid, which might not be what some organisations want to do. And that possibly, I mean, maybe we're seeing some examples of that. So there's a bit of renewal going on in the third sector as well. Okay. Right, do we have any other contributions on this? Or can we just go to the recommendations now? Okay, so we've got recommendations on page 70. So we're noting the outcome of the consultation process and the proposed implementation plan with the transitional phase up to the 31st of March, including arrangements made to support current providers through the situation. We're approving the future model. I think it's clear that everybody who's contributed has said that they're willing to do that. And we're approving funding for current providers during the transitional phase. And we're making the direction of Appendix 3, which is asking us to procure the service provided by the Living Well Cafe until the 31st of March. And we're instructing the Chief Officer to proceed with the implementation of the new model. So we're all content with that? Maggie, do you want to come back? Your hand's up. No?
No, sorry, I thought I put it down.
Okay. Right, so we're agreeing all those recommendations then. Right, I think I need a 5-minute break to go and turn my central heating on because I'm frozen. So if you wouldn't mind, we'll take a 5-minute break and come back at 12:15 to finish off the rest of the agenda. Okay. Thank you.
Chair, if I can just suggest an opportune time, given that the remaining items are restricted.
All right.
Is that right?
No, I don't think they are.
No, they're not. Sorry, I'm looking at the wrong paper. I'm looking at the wrong thing. My apologies.
That's all right. Okay, see you in 5 minutes. Right, do we have people back?
Yep.
Everything's here. Let's just give it another minute or so. What happens in other committees, Derek? Do we do another roll call to check we're still quorate?
Yeah, what I was going to suggest, Chair, is I won't do a full roll call, but I would just look to do the quorate voting members so that any decisions are valid.
Yeah, okay. John's here. Okay, shall we try the roll call and see if we're back?
Thank you, Chair. Yourself is here. Luann Grugan, are you back?
Yeah, I'm here, Derek. Yeah.
Thank you. Councillor Cook?
Yep, I'm here.
Councillor Bell is still not, he's elsewhere. Councillor Dunbar?
Yes, I'm here, thanks.
Thank you. Kim Crittenden? Kim not here yet. Alan Gray? John Tomlinson?
Yes, yeah.
So that's the voting members confirmed who are in attendance, and that makes you quorate. 2 plus 2.
Okay, so we're on item 14, which is transformation decisions on action 15. Who's going to speak to this report?
Chair, I'm back again, but I'm not planning on speaking. I think Louise, officer, although I think she might have come off, but John Donachie. John, are you still here?
I'm here and John's here, and
Oh, yeah.
I think Alistair Jimison's here as well, because we were all involved
Okay.
in its preparation. Will I kick off? The reports that were submitted here is for the Action 15 spend that we're looking. The first one is the first contact. Now, this project came out from a lot of the consultations that we were doing in the communities as part of the part of the research that we did for the development of our local mental health strategy and plan. And it was a lot about people wanting things more in their community and more in their area that they could access without having to go to GPs. And I think from other stats and such that we've had from our link workers that are attached to GP practices, that a lot of their work is mental health. So we looked at our being able to develop a specific mental health link worker within the communities, but equally to be able to have access to them without having to go through GP practices and put another burden on the GPs. We were also looking at the peer support workers there. This is a model that's been looked at and tried successfully in a number of areas, and been in contact with Tayside where they've rolled it out very successfully, to look at the community capacity, community building, a more flexible service, and again, a more preventative type service upstream to allow people to access and, before they come to the tertiary services, the primary care services and such like. I think that's one basic things. I don't know, Alistair, would you have anything to add?
Yes, I think that is very much sums it up. We're looking for more potential of self-management type supports within this and demedicalisation where appropriate, but also very much integrated and working collaboratively with other services such as GPs, link practitioners, etc. Principals are asked once, get help. We're looking to link into services that already exist currently and optimise the use of them, such as link practitioners, distress brief intervention, and of course the multitude of good community supports which people in distress with mental health may not be aware around and how to access. So a significant part of this role, as well as the first point of access, fast access, would be to support within signposting and navigating of care to vulnerable people with mental health. We're looking particularly to cite the services within areas of deprivation. We have proposed 3 teams of 3 workers, 1 mental well-being worker and 2 peer support in each locality. And as mentioned, support in navigating services. One element as well will be within the proposal will be identification of potential gaps in supporting our communities and our third sectors organisations towards finding and filling these gaps as well. So I think that probably sums up from my perspective, and hopefully, yes, reducing pressure on primary care, which is often not the best service for people to come to in this situation, and give them an earlier preventative opportunity.
Can I also just maybe mention as well that primary aim originally for Action 15 was really about diverting people away from key locations such as primary care, custody and A&E. So the model that we have, it's taken a lot of work to look at selling a demedicalised response to distress. So that's been quite a challenge to just create that cultural shift in emphasis. We had a recent meeting with representatives from the Scottish Government last week. So again, I think going forward, the mental health strategy may well reflect the change that we're hoping to embed here, which is not about key locations, but about diverting away from those key locations and to minimise the kind of footfall through, through those pressure areas. So we're hopeful, we anticipate that this model will go quite a way to, I guess, creating an additional part into that existing pathway of services. I think as well, part of the challenge that we've noticed over the last sort of 6 to 8 months really has been, as people have, other contributors to today's meeting have said, the response to COVID. So as a consequence of that, we've had to, again, continually kind of remodel our thinking, because some of the key players are NHS 24. So in the last sort of 6 to 8 months, NHS 24 through Action, I think it's 13 of the strategy, also have centralised government money to develop a mental health hub. So we anticipate that these workers will in some way gain support or fit into that pathway as well. And also the distress brief intervention model that's rolled out across Scotland. Aberdeen's been fortunate that Penumbra have provided workers that have given us that capacity over the last couple of years. So this is probably, I think there's also a little bit of appeal from myself for an opportunity for some evolution of this model as well over the test period, if that makes sense.
Right, thank you very much for that overview and explanation of the paper. Over to board, any questions and comments? Luann.
Thanks, and thanks for this proposal. I think it's exactly in the direction of the strategy, which is all about doing things in communities, early intervention, and the really important role of lived experience. So I think it's a really exciting initiative. My reflections on it are probably just around, there's a lot of new developments coming up. So we've had link workers already, we've got distress brief interventions, we've got alcohol and drug community services. Is there some sort of overarching group that's looking at how these all work together and mesh together, so that we're not having one person bouncing around all these services, but we're coordinating that well? So that's my first question, is about the community bit, but also, is there a clear pathway for people who need it to get into the medical services, who need that, and also how the psychological resilience hub would fit in with that as well? So my question's about coordinating it all, but also flow. I would be concerned, given the mental health impact of COVID, that 9 workers sounds like a lot, but it's not. And that could, if there's not the pathways built in, they could get kind of really full with seeing people really quickly. So it's just to get a better understanding of that really, but I think it's a great and exciting proposal.
Maybe I could come in on that. I agree completely. I mean, it can be a very complicated pathway for somebody that's not feeling very well to negotiate themselves. So we have become very aware of that. We're just about to embark on a full mapping exercise of all our commissioned and non-commissioned services within mental health, and ACTFO's involved in that as well. And from that, we'll also be hoping to identify unmet needs from there and see where we can go forward. We are very aware that we don't want people to be going down in the loops and round the loops, so we need to have the interfaces between these different services quite clearly set out. There is a slight bit of ambiguity because of certain things that have been set up as a result to COVID, and we don't know the future financing and how far it will go, at what level and such like. But at our mental health partnership groups, we do hope to, bring everything together there. We've got third sector providers, we've got different representatives on that group. But as our mapping goes ahead, we hope to be able to sort of plot where somebody would go, how they can fit into and be referred on to different services. And I think at any time during that service, somebody can, that flow, the whole spectrum, somebody can come out and go on to be referred to psychiatry, Cornhill or whatever. So they don't have to jump through every hoop. I think it's just the options that people have. But if it becomes evident that somebody is needing very specialised support, then yes, our referral procedures still remain that somebody can access that.
Thank you. So it's a sort of no wrong door approach, really. Somebody can come in at any point and everything will be joined up through the mapping work. Yeah.
Yes. I think what we had acknowledged is that we had a lot of the tertiary services, and as Alistair said, the GP services. We really need to develop our community services for your level 1, tier 2 type people. It's the preventative getting upriver to try and avoid people having to get to that service, and it's getting the appropriate service. But I mean, it's not necessarily linear. You can jump in and out depending on your issues, depending on your situation and circumstances.
Thank you.
Okay, John Tomlinson, then Leslie.
Okay, yeah, thank you. Yeah, welcome the report and the design of this. The conceit of it is really good, and what I'm mindful of is the capacity to be able to produce this. So you've got the assumption that that there will be people out there, and I suppose this is more of an observation rather than a direct question for today, but to some extent, we might be recycling people from existing parts of the system into this, which might be fine if things are moving and changing. But I think it's maybe something that we'll need to be mindful of through the workforce strategy, just who's out there, who we can bring in. That there have been some other initiatives that have kind of stalled because the design's been there, but then couldn't get people, so that then it's been redesigned. So overall, we have a delay. So I suppose it's just more of an observation at this point that workforce planning, in light of where we are currently, will be important for us as an IJB, and it links to a theme that's come up 2 or 3 times, which is that capacity into the community. Because if we're signposting into the community, there's the question of what infrastructure is going to be needed at that level in the future. So it's more just of a comment, and in future it can come through in these individual reports, but it's maybe something we need to revisit in our whole workforce strategy. Thank you.
Okay, that's a good point, John. Leslie.
Hello, I also welcome the report and the approach, the model. My question's very specific in terms of maybe the level of discussion and consultation that there's been with Police Scotland. I'm aware as a ward councillor that there's often, that they may be the first contact sometimes with people who are in distress.
The police have been on with Action 15 board. They're represented by an inspector, Ian McKinnon, and he's been involved in all of our planning and such. Now, we were very aware that a lot of police time is taken up by people that have got mental health distress and such. So we very much included them and tried to accommodate what their needs when we were going planning this. And we're offering that flexibility of hours and weekends in an aim to also help the custody suite as well, so they can use that as a means for directing people and such. So we have had the police involved quite a bit.
I would say, Councillor Dunbar, that as Louise said, we did work very closely with Police Scotland. And Action 15's aim is really round about the custody suite and support there, as opposed to Police Scotland in general. But locally, the information that we had, the data that we accumulated, indicated that actually it would make much more sense for us here to support the Police Scotland and some of the individuals that they come across, you know, in the course of their day-to-day policing activities, as opposed to simply the custody suite. So we've kind of shifted a little bit from the government's aspirations, but again, I think the recent meetings we've had with Scottish Government have indicated that we've actually chosen the right approach, is what they're saying. They're happy for us to be flexible, to look at flexible approach to local needs, as opposed to a centralised kind of government diktat of what we should and shouldn't do, if that's helpful.
Yes, that's helpful. Thank you.
I think it would be hoped that some of the strain on the police would be removed by the provision of this front-facing service, Councillor Dunbar. Obviously, that would need to be assessed within evaluation, but rather than coming to a crisis point, as with presentation to general practitioners, sometimes the police are hit with things that could have perhaps been dealt with if there had been services at a visible point within our communities. It would also provide support to them in terms of a place for support where they do come to police still. I know the police have been very appreciative of the Penumbra Distress Brief Intervention Service, and in a way they're doing what GPs often do, is what's called DBI 1, Distress Brief Intervention 1, the first contact. Penumbra are doing the second point contact, taking things on from there. So hopefully this service would provide, in effect, a DBI 1 that the police are currently providing a lot of work around.
Great, thank you.
Okay, John, I see John Tomlinson. I see your hand up still. No, okay, that's fine. Okay, John Cook now.
Thanks. Yeah, actually, it was a comment rather than a question. I thought it was a really good paper. Reading it, I thought everything's going in exactly the right direction. And I think just to kind of, one of the things that occurred to me was that in only September 2019, we agreed the out of hours hub, and just over a year later, we're changing it. I actually think that's a sign of maturity, because what we're trying to do, we're transforming things. We're going to experiment. Some things we're going to get wrong, and it's you know, I'm a politician. Normally, we don't like to do U-turns, but actually saying, no, the world has changed. Let's try something different. I think I just think that's a good sign.
Yeah, no, I completely support that comment, John. And I think we're going to see a bit more of this, because COVID's forcing us to do things in different ways, but it's also making us rethink whether actually did we actually get it right first time. So like you, I think this is fine to tweak the approach, which is what's happening now. And I'm glad that there's been discussions with Scottish Government, because this is funded. Action 15 money is specifically rings fenced, so we do need to make sure they're comfortable with that. And I'm glad that's happened. Right, Luann and then Maggie.
Thanks, Sarah. It was just occurred to me, closing the loop on the recommendations, that maybe we should have one that clarifies that the reporting on progress around this would go through RAP. I presume that would be what I would think, and as thinking of what we did with link workers in the past.
Mm-hmm. Yeah, absolutely. The transformation, well, I think that's taken as read now, isn't it? Because all transformation projects go through RAP. That just happens. So I'm not sure, do we need a recommendation about that, or will it just happen? Sandra, Alex, what's your view?
The the updates do, yeah, would just happen, Sarah. I think it is agreed, but belt and braces for a recommendation.
Yeah, sure. Okay. Okay, we'll specifically reference it in the recommendations, and Derek can get his drafting pen out and come up with something. Okay, and Maggie and then Shona.
Hi, it's just a question about timings. On the report, on page 134, there's a description of the key milestones and the approval dates, and then procurement. And under procurement, there's target dates of September to November. And I'm conscious that we're in, obviously, we're nearly at November now, and implementation is mentioned as December. Can I have some clarification on whether those dates are, how those dates will be adhered to, if they are, or whether they're being changed depending on what's been happening with time pressures?
I think that's a good point, Maggie. I agree. I think that we will have to revise what those dates are. I think we've been reacting a bit. We've been waiting for some other info from government and such like. So yeah, I think that will have to be extended, but obviously we'll try and get this commissioned as soon as possible and get the service there.
That's fine. Thank you, Louise.
I'll come in quickly, sorry, for you, Shona. I'm very mindful that the links commissioning process took longer than we were expecting. And I'm keen that we don't repeat that, because there's pressure to spend the money, as we've discussed previously about Action 15 monies. And so the length of time that it takes to actually get the service started is a concern for us. So if you could be mindful of that when you're looking at the extensions.
Yeah, I think we had discussions over which commissioning route to go. We're going to go through the ACC commissioning route because I think there's a bit more flexibility about the information sharing and such as well. So we have had discussions about that before, and I think we are appreciative of the timescales and such. But no, we're hopeful that we can get something progressed quite quickly.
Okay, fine. Okay. Right. Maggie, do you want to come back in? Or you fine? Right. Shona.
Hi, thank you for a very interesting report there. My query is actually relating to how this actually works within the community with mental health services. I think it is a good thing, but how does this interact with people like CPNs who, and I think this is a specific case that I may actually feed back to the IGB, because it does concern me, about perhaps decanting into this system before it's fully formed, i.e., you know, if services for mental well-being is actually being directed towards the police instead of being dealt with in the community.
I guess there's probably this would be a different tier of approach than a CPN, for example. So this service aims to capture folk in distress earlier on who wouldn't necessarily come to the attention of specialist services. At the moment, because there isn't this opportunity to have an early doors discussion except through a general practitioner, which then results in a referral to specialist services, the aim, the objective for this project is to create that pathway so that people don't necessarily need to approach their general practitioner in the first instance, or approach Police Scotland if they're in distress and don't know where else to go, or approach, phone 999 and ask for an ambulance. And SAS might then alert, GMEDs, who then might alert, the out of hours specialist mental health services to do an assessment, who will then discuss with with that individual that their needs are at a level that don't meet the need for specialist input, so they kind of are left feeling unsupported again. So the aim for this project is to create that tier of support that doesn't currently exist, because lots of individuals perhaps don't meet the threshold, for want of a better word, for treatment from specialist services because they're not needing treatment. What they need is kind of a compassionate conversation, someone to be alongside them, looking at some skills acquisition, look at an opportunity to discuss relationships or other pressures that are kind of impacting on people's lives that will have an impact on their mental well-being. So maybe anxiety states, an alteration to their mood, a change to their sleeping pattern and diet and things, which don't necessarily need a medicalized response. So this really aims to create that initial opportunity for a discussion about somebody's sense of well-being before the requirement for a referral to specialist service.
Yeah, I totally agree with you. I think there is a scope between, obviously, people who are not well and are perhaps not mindful to actually self-refer, and that may end up with a criminal record as a result. But there has to be some intervention in between so that they then don't go into commit, or if there's further information that people have that can be fed into the system. Regarding carer input, how much would that be taken into consideration? If they suspect that something is perhaps a little odd with the behaviour, would that be taken into consideration at all in something like this?
I would say yes, definitely. We've had robust links with VSA Carer Service in mental health, and Arlene, that was the worker there, has been involved in various groups and things. So, I mean, I can always see us maintaining strong links with the carer services. And I mean, we very much take heed of what the carers have to say to us and such.
Okay, thank you very much for that. It's much appreciated. Thank you.
Okay. I don't see any more hands up. I think we've had a good discussion on this paper, very comprehensive answers, which is great. So we've got recommendations, page 99 and 100. So as John Cook mentioned, we're cancelling the out of hours hub business case that we previously approved in September 2019 for reasons explained in the report. We're approving the expenditure set out in the business case as Appendix 1 relating to mental health first contact support project, which amalgamates and supersedes the mental health and wellbeing out of hours project. And we're instructing the Chief Officer to make the direction for the first contact support project as per Appendix 2 and to issue that direction to Aberdeen City Council. So we're content to do that. Great, and we'll add an additional recommendation on the belt and braces approach principle that monitoring of this project will go through the normal transformation monitoring processes for RAP. Okay. Right, great, thank you. And right, so we're on to our final item of the day. Once I get to it, it's a very long business case. Right, item 15, and then we've got some any other business as well, quickly. So we've got more Action 15 decisions to do with HMP and the Young Offenders Institution. So is this the same team of people? It is, right. Okay, do you want to give us a brief introduction to this paper and then we'll take some comments and questions on it?
Okay. This paper, it was joint work with Aberdeenshire, and Aberdeenshire took the lead because they have HMP Grampian within their area, and it was to develop and enhance the mental health support for the population of the prison. We agreed on percentages of costs, and I think in the business case there, it does outline what the population percentages are at the prison, which includes out of area, so they're not necessarily Aberdeen City or Shire, but they could be Moray or anywhere else. So we have split the costs accordingly to meet the needs. The Aberdeenshire looked at various models, they did the research there. I think you noticed in the paper as well that they've said that in Aberdeenshire that they're going to be employing an additional worker, a field worker, to sort of liaise with the prison service as it is. And this is something that we're looking under with our substance misuse service as well, if we can create greater links in the same way that they've got there. So the proposal being that we have the OT and the Band 5 mental health practitioner to work within the services that's there already, looking at a very functional approach but also sort of looking at the DBI approach and trying, I think, to offer the support and the links into the community there as well.
Sorry, I couldn't get my mute off there for a moment. Thank you for that. Right, any questions and comments on this? No. John Tomlinson, and then Luann.
Yes, thank you, Louise. Yeah, I think it's at yeah. Just as a general comment, is the Moray population served by this as well, or do they come in the any other areas bit, and therefore is there a financial contribution from there? So that's one question. The second one is I think it's on page 157 where you've got the scoring on this. So I was just trying to get my head around it. So this is money that we get from the Scottish Government. Mm-hmm. So if we did fund the option plus, if you like, which costs a bit more, I'm assuming it would be a better service, and we're getting the money anyway. So I couldn't quite square that off, that actually we don't want to do that, because it's the option plus. It's not like a different option. It's an addition. So yeah, if you could comment on that as well, please.
Yes, out of area is Moray is out of area. We're not getting money from Moray for this. I think we were doing this in partnership with Shire, and they've already committed their money from their Action 15 to a number of different services, and they only had a limited amount that they were able to give towards this project. And so I think that looking at the weighting of it and what we were contributing towards this from the city, and to keep the percentage in line with the percentage of the population and such, that's why that we've gone for this.
Ah, okay. That's not explicit in the paper then, and would seem to be a different factor from what's in the scoring, if that's actually.
Well, I mean, yeah. Mm-hmm.
So I'm not. I mean, that just begs the question of what the difference is. What's the additional outcome that will be delivered? Because then we can take a view about the resource issue around that. As it stands, it's not clear.
Mm-hmm. I mean, I think this would be something that we would be evaluating as we go along. And as we're also still looking at our ADP to see where we can put extra input from into there as well. But no, I do take your point.
So are you advocating option 3 then, John, rather than option 2?
I'm advocating understanding the difference between option 2 and option 3. Therefore, and without that, I can't really take a view on it. So, I mean, I don't want to hold things up as such, but I'm just feeling a bit, yeah, that's not from my point of view getting evaluated clearly, and certainly the scoring option. Yeah, so I'm not quite sure what to suggest here.
Okay, so it's pages 155 and 156 of the pack. Now, my reading of this was that there seemed to be a concern if we augmented the service with the brain injury psychologist, there was an increased concern about creating a demand that the rest of the system couldn't meet. That's what I understood from the first bullet point in disadvantages, and that it's a significantly increased team in terms of size as well. So. Yeah. Right.
Yeah, well, that still doesn't make it explicit what, if the need is out there and then it's not met, there's a consequence of that. So
yeah, Alex, I see your hand. Do you want to come in? You're going to be helpful here.
Well, I'm not sure I'll be helpful, Chair. I think one of the potential issues is it. I guess what's happened here is that when it went through the options appraisal, obviously the third option has got more from it, and it's whether the points in terms of the additionality that you get from that additional option need to be reflected against the resource that's available. So you can see when you look at the scoring that the resource available is, is the make weight, or in terms of what's there. So I just wonder then, given what John's saying and what's happening, could we wait till December to make this decision? Would be a question to the report authors, and we could come back with further information.
I'm trying to understand some of the detail in the business case as well, because it was Aberdeenshire colleagues who produced it, and were central to the discussions and led. So neither myself nor Louise were on those steering groups. So yeah, there's I suppose there's a bit about the brain injury being a specific focus, which isn't really reflected, I don't think, particularly strongly in the business case either, to decide, well, why choose that kind of subspecialty, if you like, or diagnostic condition, if for want of a better question. I guess there may well be to do with substance misuse and things.
It sounds like we do need to defer this to get some further information, actually, because John's point is very well made about there is the funding for the more expensive option. If the constraint is that there's no confidence that you can recruit people, then that should be spelled out, I think. So yes, I think that's a helpful. Are you content to do that, John, is to get some more information?
Yeah, absolutely. Yes, as long as that's not, making a material difference in delaying it. But I think that would make a more robust decision.
Yeah. Okay. Well, I'm happy to do that. So, okay.
Thank you.
Yeah.
So if you can go away and give us some more information on the rationale behind the business case, then we'll consider it again in December.
Yeah, Chair, I think that's what we would do. We'll go away and we'll have a look at the business case in a bit more detail, bring a bit more rationale out there, but also look at how it's being scored. Because I think it's the finance one, and that's what sometimes that we lose, is that you could develop the best model in the world, but if the finance option isn't properly weighted, then you end up in a position where you've spent all your money, you don't have any money, but you've got the best possible service option. So it's almost as if there needs to be some weighting around about some of that stuff, but we'll pick that up and we'll bring the report back in December.
Okay, right, I'm happy with that. So we'll just defer this for a cycle. Thank you very much for today. I'm sorry we didn't get both of your decisions made, but we need to be sure we're making the right one. Great. Right, we're going to go into private session now for any other business. So if you could turn off the recording, please, Derek.